chapter of IFSO, and I extend to you all a warm welcome to a very exciting webinar that we're going to have today. We have an excellent topic. The main topic is ergonomic advantages for in robotic surgery. Are they real or is it hype? And we have two amazing speakers. And I think we're going to learn a lot today, and then follow that with a discussion. So, thank you for attending, and please, once you hear the presentations, feel free to ask questions. I would like to generate a very lively discussion. I'm going to start by introducing our speakers. Dr. Ann Rogers is our current president of the ASMBS. She's a professor of surgery and vice chair for faculty development and the director of Penn State Surgical Weight Loss Program at Penn State University. We're also very fortunate to have Dr. Todd Wilson. He is a professor of surgery at McGovern Medical School here in Houston, Texas, and he will be giving the second presentation. We have Dr. Jaime Ponce, that you all know. He is the past chair of the North American chapter of IFSO and also a past president of ASMBS, and he's been very active in IFSO and advancing its missions. We also have Dr. Megan Jenkins. She's a clinical assistant professor at NYU Grossman School of Medicine and associate director of the surgery residency program. And of course, we all know Dr. Marina Kurian, immediate past president of ASMBS. She is a clinical professor, Department of Surgery at NYU Grossman School of Medicine. And as you can see, we have a stellar cast here of panelists and speakers. And without further ado, we'll get started with the presentations. So Dr. Rogers, please go ahead.
All right. So I'm going to be starting it off talking about ergonomics. And I suspect my talk won't be as complex and meaningful as Dr. Wilson's, because he's a real expert. But I'm just to get us started, I'm going to talk about this. These are my disclosures. They will have no bearing on the talk. I think a lot of people are not worried about ergonomics, and I think they should, because nobody thinks they need sunscreen when they're young, but everybody does, and it's something that we need to start doing. So when I'm proctoring young surgeons, they don't actually believe that they need to stop hurting themselves, and they don't believe that laparoscopic surgery is leading to problems, but it does. I don't know if everybody knows that the American College of Surgeons Board of Governors has an annual survey, and they send it out to, basically all of their members, and it's a way of, they come up with the survey every year. And in 2017, the survey was on ergonomic injuries and how to prevent them, and it was a really interesting survey. And first of all, they asked people, have you yourself ever had a work-related injury? And only 19% said yes, but 41% said they had definitely had a colleague who had. Maybe it was all the same guy, I don't know. But then the question was, does your hospital have a program to address and prevent ergonomic injuries? And very few hospitals do. I looked at my own hospital, and basically they have two slides on it. One is that you should lift with your legs and not with your back. And I think this was amazing. This was on Physician Moms Group about a meme. You come across a van full of money. What do you teach your child? Lift with your legs, not your back, right? So it's very helpful. But the other slide was, you should push instead of pulling. So that was all that we get at my hospital about preventing injuries. And I've suffered innumerable musculoskeletal injuries from laparoscopic surgery, such as, neck positioning. I've torn my posterior tibial tendon. I've gotten tennis elbow, and it's not because I was playing tennis. It was because I was operating. I have pretty bad arthritis at the base of one thumb, and a friend of mine who's a hand surgeon told me that's actually the most replaced joint in the United States. You'd think it would be hips or knees, but it's actually the base of the thumb. Who knew? And I've had plantar fasciitis and Achilles. And all of this is from the strange positioning that we tend to be in when we're doing laparoscopic surgery. And that was my main motivator for converting to robotics. Now, Adrian Park has sort of become the world's watchdog on surgical kinesiology and ergonomics, and he makes it clear that anybody who operates is at risk. Surgeons suffer while patients benefit. 87% of surgeons have experienced neck and back pain during minimally invasive operations. Women preferentially get upper extremity and neck pain while operating. This apparently is also true with the currently available robot. So hopefully the newer iteration is going to help with that. Even assistants who are helping with this kind of surgery are at risk. So I've taken pictures of residents and medical students, and they're always bent over like a shrimp, and it's terrible. And something needs to be done. This was a paper about an ergonomics workshop aimed at improving musculoskeletal symptoms in surgery residents, 100% of whom reported having musculoskeletal pain from operating, right? And, much of it is from a standing position, so I'm lazy and shiftless, and I'm going to try to avoid that at all cost. And it tends to be lumbar pain, cervical pain, and, there's just a clear trend that surgeries with longer OR times, of course, are going to increase your ergonomic risk. And I'll just make note of the fact that revisional bariatric surgery is more and more and more common. So our operations, by definition, are going to take longer and longer. So it's something to worry about. This was a paper in JAMA Surgery on ergonomics for surgeons, and they talked about a number of things, and they made the point that good posture is important, prolonged standing, lead aprons, loops, strange positions, you need to take those things into account, or you will end up getting injured, and it could shorten our surgical lifespan. Do no harm except to ourselves. This was a survey of oncologic surgeons, 28% of whom had suffered an injury while operating, and 66% of those people had undergone some sort of therapy for that injury. This paper on ergonomics in the operating room was from the Dutch Society it's like SAGES, only Dutch, DAGES. 68% of those people surveyed had suffered a musculoskeletal injury while operating, usually in the neck, the back, or often the right deltoid, because most of us are right-handed. And 38% of these people were currently receiving meds and/or therapy for these injuries. And 27% required leave from work. I mean, we just keep working through the pain, and it's nuts. So this was something on ergonomics for orthopedic surgeons. This is my only video.
I need to fix it.
There is a fracture. Okay. I need to fix it. But so they themselves are getting fractures, and this paper talked about positioning in order to not hurt yourself, and ergonomically designed hand tools so that you don't hurt your hands while you're operating. Turns out prolonged laparoscopic surgery is associated with an increased risk of vertebral disc prolapse. It's horrifying. This was sent to the British Society of Gynecologic Surgeons, and 15% of them had had a cervical disc prolapse. And so that takes us to your friend and mine. This is a very well-known American robotic surgeon. And the spoiler alert is this incision on his neck. He was operating on a patient with a BMI of 112, and the patient was simply enormous. And he says the table gave way. So automatically he went to catch the patient, and he suffered an immediate cervical disc herniation and was essentially in the OR semi-quadriplegic, right? So luckily he was in a hospital. He was immediately taken for surgery, and he had to have this spacer put into his neck in order to be able to live and keep operating. And he said that was his major motivator for converting to robotics. So this is from the Robotic Bariatric Collaboration, and this was sent out some time ago. And this guy, Curtis Peary, who's a robotic surgeon, asked people, why do you do it? And the vast majority of people said for ergonomics, but there's a lot of other reasons for doing robotic surgery. And I'm not doing this to sell robots. It's just that it's easier on the body. And this guy said, I'm 72 years old. And, having the robot has extended my surgical lifespan. Hopefully he's not, debilitated and demented yet. I think probably not. So the American College of Surgeons, based on that survey, sent out these recommendations, and they're like, stop, you need to be in a better position when you're operating. This is insane. Okay. And they talk about, good positioning when you're standing, when you're doing open surgery, when you're doing laparoscopic surgery, when you're seated at a console. And I have to point out, Mr. Bill is screaming, this is not a good chair to use. You should not use this kind of chair or this kind of chair or this kind of chair. You need a chair that locks, that pulls into the console and locks when you're going to be doing robotic surgery, or you're going to be holding yourself in position with your back. So further recommendations, they've got this guy stretching in a variety of positions. He was like, maybe he was just yelling at the fellow. And I just found this. It was a thank you note from my fellow who graduated in July. And she said, I'm not sure how I'm going to survive without your voice in the console screaming at me. But at least we were seated in the console, so there was less screaming than if we were standing. They have all sorts of things. Use a foam roll. You're supposed to, on the floor of the OR, stretch and relax. I think it's rather amazing, some of their recommendations. They have lumbrical stretching. This is my favorite lumbrical stretch. But anyway, so here's Adrian Park again. He was the keynote speaker at the first annual meeting of the Society of Surgical Ergonomics, and I'm a member of this society. And it's really important for surgeons to know what are the best practices to improve their well-being and prolong their career. So there was more good news. Do you consider ergonomic issues? Yes, the vast majority of surgeons do, and they think about table height and where the monitor should be and blah, 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 and the floor mat and all sorts of things. Does your hospital consider it? Much, much less. So we need to bring that to their attention. There's a lot of things you can do to improve ergonomics, such as taking little micro breaks, because we are at such high risk for workplace injuries. Loops are bad, lead aprons are bad. You're supposed to take breaks or pauses. So, answer that call or send somebody a text. It may significantly improve things, and one study actually showed even improvement on the FLS exam with taking these micro breaks. So the bottom line is we need to all talk about ergonomic issues. We can't just ignore it. They are real. We should not suffer in silence. And, you got to recognize that you are in pain and do something to make a change. So I will stop there and stop the share.
That was amazing, Dr. Rogers. Thank you so much. Next, we will watch Dr. Wilson's presentation, and then we'll open it up for discussion.
Hello, I'm Dr. Todd Wilson with the University of Texas, and I'm here to talk about robotic ergonomics. Is it all the hype? Now, ergonomics is extremely important. It really minimizes the repetitive strain injuries, musculoskeletal disorders, and fatigue, which are very common in physically demanding jobs such as surgery. Being able to really maintain the best of ergonomics is going to allow us to lead happier, more productive, and longer careers. And right now, there's a lot of information that really suggests that robots are the answer when it comes to workplace ergonomics. And there's a lot of information that shows that it's better than laparoscopic surgery and makes it easier for us to overall work. To really understand what that means, though, I think we have to go back into understanding what the principles of ergonomics are. And a couple of the key principles, I think, are understanding neutral position and understanding what that comfort zone is, where we're more likely to work. Now, there's clearly some effects of ergonomics that we do see, in that we can go through robotic cases and feel a little bit more relaxed. But are there things that can be improved? Now, this is just information from the CDC on what neutral position is and what recommendations are when it comes to ergonomics in general. The neutral posture in general is being set either standing straight or sitting straight, having your wrist in a straight position with minimizing radial deviation, ulnar deviation, or flexion or extension. When it comes to the elbow, the elbow should be right at our side, and it should be forward and at a 90-degree angle with minimization of flexion and extension. And in that regard, we should also have the top part of the arm really flush with the body and in line with the body without moving it forward or backward excessively. This also includes our shoulders, where we're going to keep our shoulders next to our side and minimize anything that approaches 90 degrees or holding our shoulders up. And when it comes to our back, the neutral position is holding the back completely straight and minimizing awkward positions that cause back flexion or back extension or any kind of slouching at the workspace. Overall, we're looking for that comfort zone. That comfort zone is that position where when we're standing, our elbows are going to be right to our sides, almost pressed up against our bodies. Our arms are going to be extended outward. They're going to be working close together. That's going to give us the opportunity to be as precise as we can possibly be and minimize the stresses on our body over the long term. But does our robot do this? Does it meet these ergonomic principles? And it's a good question that actually has been looked at quite extensively. This is one study that goes into some video work where they take surgeons that are practicing. These are robotic surgeons with lots of robotic experience, and they just film them. And what they've done is they've broken down the angles at which they sit in order to do their robotic cases. These angles that they're looking at relative to the body are the same angles that people look at when they investigate ergonomics in the workplace. This is a diagram that depicts each of the 6 individuals that were followed in this case. And what we have here is a breakdown of the angles of the elbow, the knee, the hip, the shoulder, neck, and trunk. And in the green zone, that's considered the ergonomic safe zone according to studies that look very deeply into what is good ergonomic practice. Now, in each of these studies, what you'll find is that there's a lot of variation between the individuals who are operating, and very little of these are actually within that ergonomic safe zone. This is one of those 6 individuals, and what you can see here is that when it comes to the knee and the hip, we're within that safe zone. The elbow is pretty close, but the shoulder and neck are pretty far outside of the safe zone. And the interesting thing is, in every single one of the participants, both the neck and the shoulder were at what would be considered harmful angles for those participants. Now, this may be because of limitations of the console. If you look at the way our DaVinci consoles are right now, the viewer angle can be adjusted between 40 and 60 degrees. The viewer height can be adjusted between 104 and 137 degrees, and the armrest 74 to 84. And if you look at the diagram off to the right, you see that safe zone, which is colored in green. Now, for each individual, you have to be able to adjust the heights of the different components in order to reach that ergonomic safe zone. And what we find is that with the armrest height, we probably only reach that safe zone in about 1/3 of all participants. Now, that diagram that you see, or the lines that you see, that's actually just data from all aspects of individuals in the Netherlands, not just those 6 participants. And on the bottom, we see the optics height, which has a wider range and covers more of the overall population of the Netherlands, but it still misses about 25% of that population. Now, it does appear that we don't actually meet what would be considered good ergonomic standards according to ergonomic studies. But does that actually translate into anything meaningful to the surgeon? In this study, There were 106 urologists that were surveyed, and out of that, they were looking at open versus laparoscopic versus robotic surgery. And just like what we've established, robotic surgery tended to have less pain than both open and laparoscopic surgery, but chronic pain was reported in 23% of robotic surgeons, and interestingly, 95% of that was neck pain. Just like what would have been expected if you looked at the ergonomic data, and there's ergonomic safe zones that we saw in the previous study. Now, there really is room to improve. You can imagine that if you have the ability to sit down and do your work compared to standing and doing your work, you'd see significant improvement in many different areas. In this study, they looked at that and compared the different operations, and they found that the robotic cases did actually have more people reporting no pain. So that's an improvement. But what I'm surprised at is that we still have 30% of patients reporting head and neck pain, and that's not very much different than open or laparoscopic. And back pain, it's 42%, also right in line with the other two, with very little improvement. Now, these are surveys. They're asking people about pain. Is there a way that we can actually use standardized approaches to determine, are we meeting the ergonomic standards? This study actually goes through that effort. And what they did was a videotape assessment. They're looking at 16 hours of video. And in that, they're breaking it down into two different assessments. One's called a RULA. And what that's going to do is act as kind of a screening tool to determine if further effort needs to be conducted. And then they do a more in-depth study called a strain index. In the rapid upper limb assessment scoring system, it goes back to those neutral positions and essentially asks, how far are we outside of those neutral positions? The further you are from those neutral positions, the higher you score on that. Once you score to a certain level, it indicates that further investigation needs to be done. Or if it's even at a higher level, it indicates that not only do you need to do some investigation, but you probably need to make some immediate changes. The strain index is one of those more in-depth investigation tools. And here they're looking for things like force, stresses, repetition, and overall stress over time. And they do it in a very in-depth manner, asking all kinds of questions to overall come up with a number to help that assessment. The results of this study are pretty interesting in that the RULA scores were 6.46 with a maximum score 7. And that means that every single one of those hours of videotape indicated that there needed to be further investigation. And when you did do that further investigation and you looked at the stress index ranged from 10 to 40 with an average of being right around 24 to 25. A score greater than 10 suggests potential hazard to the operator, and every single hour was 10 or greater. Clearly, there's room for improvement here, and you can see with that red line, we're far from where we need to be. A review of the literature actually supports this, and there's lots of different papers that kind of talk about the different work injuries that we see related to surgery. This one is a specific meta-analysis where they're looking at robotic-assisted surgery compared to non-robotic assisted surgery, and they find that there's work-related musculoskeletal disorders that exist in that surgeon population. This isn't a causal analysis, but it certainly shows that there are some differences. And it seems that we shift those pains, and specifically there were significant differences, statistically significant differences when it came to shoulder pain, back pain, and thumb pain. Now, these are related to the robot in some way, but is it always the console's fault? Is it the design? Or is it how we're using it? And this study would suggest that if we just do a little bit of work to really understand how to ergonomically prepare ourselves for robotic surgery, we can actually make a huge difference. And what they did was they took people who were training on the simulator, and they had a control group where they did not undergo any kind of ergonomic instruction, and another group where they went through a whole setup where they learned how to ergonomically adjust the robot and learned how to ergonomically set themselves up for success. Then they did a multitude of different exercises. And what they found is that the RULA score for both the left and the right body halves were significantly improved if they had training. And even more interesting is that their scores on certain things, especially things that required manipulation of hand and feet, that required a lot of clutching, they improved their performance and they improved their ability to learn. So not only was it ergonomically superior, it actually made them better at learning and better at surgery. Now, these were novices in the learning phase, but you could imagine that that could certainly apply to those people who are already experts. Now, I do believe robotics isn't all the hype at the moment, but I do also believe that robotics is the answer. Robotic surgery empowers us to create whatever user interface that we want. It detaches us from the end effector, and we can create whatever controller it is that ultimately reduces that physical demand and the mental demand, that makes it easier on us to perform good and accurate surgery, and that ultimately should allow us to lead longer, more productive surgical careers. Not only should we be working on the console itself and designing a better product, but we need to focus on how to train people to use it right. If we do all these things, we're going to continue to see improvement, and ultimately, robotics and robotic ergonomics will be all the hype. Thank you.
Wow, that was masterful. Two fantastic presentations. Well, I learned today that ergonomics is important. We know this. We know this, obviously, but it's not forefront in our mind when we're practicing. We only realize it when we go home and wonder why we're hurting so much. So I think today's talks really, you all made a strong argument for us to pay more attention to our bodies when we're operating so that we can help more people. Dr. Wilson, do you think that we are not doing a good enough job at training the novices, so to speak, or other surgeons on how to, when they're sitting at the robotic console, on how to set it up so that it's at optimum positioning? Or do you think the technology isn't there yet?
I really think if I were to weigh it, I think that at the moment, the technology isn't quite there. And I think a lot of it has to do with the fact that it made a difference. And when we look at ergonomics, we compare it to what we know, which is open and laparoscopic surgery. And it really has improved that. So we feel like we've won. But the truth is we've got a long way to go. And I think that the design is going to be the primary component of making that a truly successful thing. If you look at the Da Vinci 5, you can see that they clearly have learned from their past. They've made some changes. The ability to manipulate that eyepiece and bring the periscope to the eyes actually addresses one of the major problems with neck and shoulder pain. And I think only time's going to tell what the ultimate results of that design change is. But I think it's going to make a huge difference. The other component is we do have to use our tools right. Training is important, and I don't see an emphasis on teaching people how to do it right. If you go to my hospital, you will find that there is 2 chairs there are 2 chairs that lock, and neither of them work. It's a huge hospital with somewhere around 100 operating rooms, and I can't find a chair that locks. And this is, a little bit of the surgeon's fault. We're not complaining enough. This impacts our lives. It impacts our livelihoods, and we should be vocal about it. But I think we need to emphasize the training, the importance of it. We also have to make sure that our workplaces are safe, and we have to advocate for that.
Absolutely. And, we do, of course, all of us put a lot of attention and effort into ensuring that the patient is positioned appropriately on the table, that the patient is well cushioned, and that the patient is safe. But when it comes to us and our own, we ourselves and our hospital don't really put the same amount of effort into helping us and protecting us from harm. Dr. Rogers, that was a great talk, and thank you for sharing your own difficulties with body pain after operating for these years. Tell me, when you transitioned onto the robotic platform, which I think is predominant in your practice now, have you perceived an improvement in these symptoms?
Oh my God, it's like night and day. But I agree with Dr. Wilson. There's a couple chairs that lock in my OR, and when you get one that doesn't lock, they say, "Oh, here, we'll just put a towel behind you, and that'll keep it from slipping," right? And then it's like, can we not get chairs that actually work? The phone in my OR didn't work for about 18 months. And when I finally smashed it with a mallet, we got a new phone the next day. So we have to do the same kind of thing with our instruments. But yeah, no, for instance, I did a very long revision on a girl a few months ago, and it took about 7 hours robotically. And I figure I'm getting better because the prior revision 10 years ago took 10 hours. Okay. And that was the one where I ruptured my posterior tibial tendon. But it was 7 hours, but I did not feel anything like I would have felt had I been standing that way. And I think it's definitely going to extend my lifespan. And when people talk about how robotics is too expensive, they got to think about how much it costs to retain or find a surgeon. It's just got to be taken into account.
So I have a question. Todd, in your presentation, you showed that slide. I wish we could pull it up again, but it was like a whole presentation on the different areas that were injured. And I saw that with the robotics, there was a much higher incidence of carpal tunnel. So someone who already has some carpal tunnel symptoms, I'm not going to switch over to robotics in that format. And you spoke also to another point, which is, the new Da Vinci does have that ability to adjust the hood to some degree. Is it enough? Is open access better when you're not stuck in a hood and looking like that? As we all know, one of our dear friends and colleagues had to have emergency spine surgery, next for his cervical discs. So 2 questions, I know, but go ahead.
It's interesting. So when it comes to the majority of the studies, they demonstrate an increased neck pain problem and upper shoulder problem when it comes to robotics, but there's clearly something in regard to thumb and wrist injuries as well, and that seems to be significant. One of the studies actually demonstrated that maybe ergonomics is going to help us solve that problem, and that is something that the Da Vinci 5 has kind of moved towards. It's a completely unknown, but it's a theoretical. Giving your ability to feel might decrease mental strain that we experience. Interestingly, we experience more mental strain when we do robotic surgery than we do with open surgery, laparoscopic surgery, or endoscopic surgery. And that one's a little bit tough to explain, but I think that maybe there's a component to really putting your effort into a screen that's not moving, and or maybe it's just that we're doing more complex surgeries. So I think that the ability to move that armrest and get to a position that works, to not have to hold yourself into the console, will probably reduce the wrist pain. Whether the new periscope technology is going to actually help reduce the discomfort that we have, I think only time's going to tell, but it's certainly a move in the right direction. My personal philosophy is we need to give people the ability to continue to adjust during the case, and the only way to properly do it is with an open console. So we need to be focusing on technologies that give us not only the ability to adjust during the case, but really open it up so that everyone, regardless of your size, shape, or how you like to sit or whatever it is, can be accommodated by that console.
You know, Megan, you are younger than all of us, and but still quite skilled and very, very busy, prolific even. When you do your robotic cases versus your laparoscopic cases, you know, from training, you're probably 90% robotic, right?
Mm-hmm.
She's flipping rooms, guys, so she needs to sometimes slump into doing some laparoscopy, you know, can't get the robot all the time. But how does that feel for you? What do you notice really ergonomically? And then as your position as program or associate program director for the surgical residents, why don't we have classes showing the residents how to be? I'm constantly trying to help them when they're doing laparoscopy and telling them, you know, you should do this, have your arms at that sort of 90-degree angle where they're either too low, too high, arms out, right? All those. Why are we not having kind of a course for them? And also for the attendings, we're all different sizes, and yet we're all operating, you know, on the same patient and have different arms and trying to climb over a patient to get to the other side to help the resident do something.
So two questions, but great questions. Thanks, Marina. So the first one, I mean, the other day I had to do an emergency case. We ended up converting to open, and it ended up being like a 5-hour case. And at the end of it, I mean, multiple times during the case, I had to like stand back and put my neck around. It was just awful. I had forgotten how much physical, you know, strain you can have in cases like that. But that's also, and I don't really feel that as much with the robotic surgery. But the flip side of that is, I think Dr. Wilson kind of hit the nail on the head. The ability to have an open console where you can kind of adjust during the case would be really beneficial, because one of the big things I think that happens is we all get so hyper focused in surgery, we forget about ourselves, right? And so I think in the current console where it's closed, I could be in an uncomfortable position that was comfortable at the beginning of the case, but 3 hours later, I realized how uncomfortable that had been. But if I had been able to be in a more open console, I might have been able to shift a little bit during the case and had a little less pain. And so I think that's a huge part of something that could improve our ergonomics. I don't think we're quite there yet, but I think that would have the ability to really improve the ergonomics for robotic surgery, obviously. With respect to the teaching, I think I was going to say the same thing. I mean, we put up all these beautiful graphs about how exactly our neck should be and our arms should be, but I can't see that in myself. I would need somebody to really set me up. And my question always is to robotic surgeons is, do you have preset kind of ergonomic settings in your robot? Because I do not. And the reason why is that I might be in a different room every day. Like, I don't know who was in that room the day before me. Their chair might be a different height than mine. And so I'm adjusting the chair, but that chair doesn't have a preset level for me. So if I kind of set the console for what feels comfortable at that time. And it's really funny because a couple cases later in the day, I'm readjusting the console, and I was the one who first adjusted that. So I think we need to be a little bit better at kind of understanding what good ergonomic posture is. I have horrible posture, so I probably set the console with horrible posture. And so I think the idea of really teaching people what is appropriate ergonomic positioning is really important. And I do think that we should do something with the residents. And I think, I always push the residents, like, we'll be starting a case and the table will be like at a really awkward height for them. It might be right for me, but they're the one making the incision, and they're always very hesitant to ask to move. And obviously that comes with experience and et cetera. But it's interesting because I think we need to be better at enabling them to understand that, ergonomics is important for everybody in the operating room. And if they need to take an extra moment or two to make sure that they're comfortable, that's important. So I think we do need to be better at classes. I think we need to be better at classes for ourselves too, because I should be making sure I'm in appropriate positioning. And it's a good point. I think it's something we should do like in orientation for the residents, and we should do during the year for the residents to reinforce it, and for the attendings also.
Megan, you're bringing a great point. I mean, I've seen robotic surgeons like sitting all weird with the hands all over the place, and I mean, they just don't adjust their their hands and their table to the right place. So my question is, we all know, I mean, I say we all, so some of us know some surgeons that have quit doing laparoscopic surgery because of many injuries, cervical injuries, back injuries, elbow injuries. I know, I mean, a good friend of mine in Nashville that pretty much was going to quit doing surgery, and then the hospital just let him have all robotic surgery. But the position of robotics is going to give us potentially different types of injuries in the future that we might not know. Do you know any surgeon that has developed an injury that doesn't allow them to do robotics yet? That's my big question. It's too early to tell, huh? Finger-wise, hand-wise?
Well,
Yeah.
Colleen Kennedy in Dallas
Uh-huh.
was in the process of learning robotics, and she found that her neck pain was too severe to continue. So that's one person. I mean, was it related to the positioning? Who knows? She wasn't that far into it, but I know she was not able to continue. But
Robotics?
yeah, robotics.
Oh,
What
wow.
Megan and Todd said was absolutely true, because in that 7-hour revision, I lost an inch of height. It was taking that long and I didn't realize it. And suddenly, somebody had to go to Pluto to get an instrument, and it gave me time to sit back and realize, oh my gosh, I've got to lower everything down. It's absolutely true. We have the technology, because cars can do it. We have the technology for the console itself to say, hey, consider readjusting. So hopefully that's coming.
So I'd just like to remind the audience, if they want to ask questions for this very interesting topic, please enter your question into the chat box, and we will make sure it gets answered. Two things we learned today. One is we're not receiving enough training when we embark on using the robot. I mean, I remember my personal experience was I was shown how to set it up, but it wasn't explained to me how to get optimum positioning. And the other thing we learned is that robotic surgery doesn't necessarily eliminate all ergonomic problems. It probably just shifts them or pronounces other parts of the body. So a question to Dr. Wilson. Do you think we're going to have technology that personalizes positioning of the robot for each surgeon? Because I can sit there and manipulate it and say, okay, this feels comfortable. But like Megan said, maybe 2-3 hours later, I feel like I need to readjust. So is there, do you think, a possibility of the machines maybe measuring my eyes, my body habitus, and then suggesting optimal positioning?
I think that there's going to be a few stages, and that's going to be in parallel with a lot of the things that we're going to see with technology. The first is increasing the capabilities in order to meet all the different variables that we need to in order to reach those safe work zones, those green ergonomic safe zones. And once we get the ability to do that, which is entirely possible when it comes to robotics, and we have full design control of that console. The other is really applying the technology to assist us in doing a better job. So if you can, go back to, this really is a mentally demanding way to operate. It's more demanding than laparoscopic and open. And as you can, see that technology overall helps us see better. And it should ultimately help us do better. And that should reduce that mental stress that we experience. And that's going to be, I think, really enhanced with artificial intelligence, with computer vision, computer-aided operating that's going to, help us identify safe zones within the operation. So mental load, that's one thing. But from a physical standpoint, I do believe that we're ultimately going to achieve that really intelligent user interface that is going to be able to teach us how to be better surgeons, not only by adding precision and accuracy and better decision making, but also in how to protect ourselves from workplace injuries and position that console in a way that it's going to be really beneficial to our longevity.
Fantastic. Any questions from the other panelists?
So, from the presenters, have you tried the DaVinci 5 console, and it's really that movable view is helps you to adjust the posture? I mean, the staying more straight or better aligned in your back when you do the case? Now
And
that
have
you
you had a chance to try the new robot?
I've played with it, but we do not have it yet in my hospital, unfortunately. I don't understand it as well as I should.
I've personally tried it. I haven't spent a lot of time on it. I am one of those individuals who find that robotic surgery personally actually is ergonomically inferior to laparoscopic surgery, where I feel that I'm more comfortable. I'm in that, comfort zone. And I feel like I can really maintain that with advanced laparoscopic cases. And if I do a long case robotically, I am wrecked for the day, and it really affects my neck and shoulders. Despite efforts that I've put into trying to make it as ergonomic for me as possible. I think that this is a good answer and a move in the right direction. I haven't put enough time on it to determine, what is it like if I do a 4-hour case that's intense and difficult. But I do think that it's going to be a big move in the right direction. I don't know if it's completely there yet. Time will tell.
I think someone else talked about, your car can do it. Like, I love my car, my seat's perfectly adjusted, but if I'm on a long drive, it doesn't matter, right? It doesn't matter because I'm in that position for so long that I still need to take a break and walk around. And I think, certainly with robotics, the ability to just pause the operation and nothing moves versus in laparoscopy, when you pause the operation, everything anything can move. I think that's helpful in sort of being able to take that step back, roll your shoulders, et cetera. I was going to ask a while ago if you guys had come across any studies talking about whether, yoga is supposed to be great for everything. So even fertility, right? So doing yoga better when you're a surgeon? Have you seen anything like that? Or is it Pilates? I mean, I saw the stretches you had out. I actually had I still probably do have shoulder impingement. And my orthopedic surgeon was showing me these things that I had to do. I went to physical therapy, actually. And these were things that I should be doing in between cases. So all of a sudden, someone will see me flail my arm out like this when I'm walking around. And it's really just to kind of open up that shoulder joint, right? So timing of stretches in between cases at the end of the day, whether yoga helps, massage helps. We always think massage helps, right? What's the answer? You guys didn't come across any of that?
I haven't seen any literature on it, but I have to believe that stuff is all good.
I'll just advocate for it. No, there are some studies that would suggest that those things that enable stretching, and that could include yoga or like a Thai stretch massage or something like that, is beneficial and ultimately helps with prevention of workplace injuries. The data is weak. It's a little bit more anecdotal, but I think that it gives us all a good excuse to go and get that massage and join yoga.
Self-care.
Marina brought up a good point in that, even if you have your car seat perfectly positioned for comfort and you drive a long way, you're going to need to readjust at some point. And I know some late model cars actually have a built-in timer so that if it notices that you've been driving for a while, it actually prompts you and says, is it time for a break? And I wonder if maybe we should incorporate that technology into these platforms, saying, hey, you've been operating now for 2 hours straight. Is it time to stand up, or is it time to readjust? Just to remind surgeons that that these things might be helpful.
Your Apple Watch already tells you that, right? Megan probably wears her watch when she's operating, and it's like, Megan, stand. Take a deep breath. Right? Things I find
it does. It tells you every hour you should stand for a minute. But Summer, that's a great point. And then, Todd brought up another point that he feels more comfortable with laparoscopy, and Marina with the driving thing. It just reminds me, like, if we parallel what we do all day, which is operate, to what some of our colleagues do all day, which is on meetings or on computer screens, whatever. One of the big things that they've started doing is having standing desks, the ergonomic desks that can stand, that can sit, yada, yada, yada. Ultimately, we should have the ability to do that too. Because if you're doing a 5-hour case, you should have the opportunity to stand up for a little bit and then sit down for a little bit. It might help prevent some of this, fatigue that we feel. Because I feel like sometimes for me, the fatigue I feel more than anything else, besides the mental fatigue after a long case on the robot, is sometimes my legs all like stand up and my knees will crack. And I'll be like, oh my God, I've been sitting for 5 hours and not really, getting blood flow through my legs or stretching my legs. And that's another aspect of it. It's not just the neck and the back and the wrists. It's also, sitting for that long period of time versus standing. I mean, it just is two different, beasts, right? Which one's worse? We don't really know. But I think, that would be a really great opportunity to be able to have, an open console that you could stand up for a little bit, then you could sit down for a little bit, and that would really allow, even more ability to kind of prevent those physical fatigues that we feel.
Yeah, that's a really good point. One of the things that I tell my trainees is, like, when they're firing the stapler and they've got their fingers in the little rings, I'm like, what's your hand doing right now? When it's firing, take your hand out of it and relax your hand, right? You don't have to. There's this tendency to clench, which we learned from laparoscopy, and just changing anything up makes a difference.
So
So
Todd,
go ahead.
I was
Go
going
ahead.
to ask Todd, for the viewers, what will be so you presented all this very good information about ergonomics. So what will be the 3 big points that the viewers needs to understand about how to position themselves on a console? Back straight, neck straight, hands in what position? I mean, what is the big 3 position messages that you can come up with that?
I think that there's going to be a few really important things that need to be emphasized. And I think Ann brought it up very clearly, is that you have to have a chair that locks into place. And that chair has to be able to be adjustable. You need to be able to move to different positions during the case so that you're not fixed in one particular location. Your chair matters. It's important. And we end up with these janky chairs in our operating rooms that are dysfunctional. In my operating room, I have a chair that literally defies friction. If I sit in it and just kind of push myself, I'll roll forever. And I have to pull myself into the console, and that's not the ideal situation. So really picking a chair that gives you ergonomic control, I think, is a critical component. You do want to sit up as straight as you can, and you want to minimize the movements that you have as far as pulling your hands upwards. That means when you're doing the simulator or you're working in the robot, you really want to minimize that workspace that you're functioning in. And that's going to give you that optimal comfort zone that's going to keep you in line with best ergonomic practices. And then the last thing is give your body the chance to shift. So during the case, you don't have to keep it all in one location. You can move your visor, you can angle it up, you can angle it down, but make changes during the case. It's important, and to take breaks when you need to. So listen to that Apple Watch when it's going off. It's not about getting the case done.
What about the neck? I mean, do you want the neck to be, is it okay to have it slightly bent, or just better, more straight, or no? I mean, certainly not like watching my phone all the time, but, something more straight or a little bend is okay.
I think a little bend is okay, but the straighter that we can make our back, the straighter that we can sit up in our chair, the better we're ultimately going to position our neck. So sitting correctly is going to be important to making those fine ergonomic adjustments. And typically that means looking a little bit more straight ahead than what we would be doing looking at a book, which is kind of what a lot of surgeons end up doing, which really promotes slouching and bad ergonomic practices.
We're all set up for failure in a way from the get-go, right? There's a meme out there that talks about the progression of man from ape to Homo sapien. And then the last
We're
one
going down.
is surgeon. And the surgeon looks like Cro-Magnon because he's like this and he's hunched over and his neck's forward. And, you know, I've been to a chiropractor before and they're like, you have to do this with your neck. And I'm like, it looks weird. But he's like, you have to do that because your neck's forward and you need to get it to go back. And so there are a lot of things that are inherent to surgery that already set us up for injury. It's not, it was never designed to be ergonomic. And then we buy into that focus and trying to make sure that our patient does well, as I think it was Megan that said, our patient is the focus. It's not about us at all. And in a way, it's our battle scars. You know, it's our own surgical machismo going in saying, I'm going to do this and I can last through the case, but you know, it does affect our longevity. And I don't know that there's an answer. And we're not alone. Like my colleague was a gastroenterologist. She has horrible shoulder issues. And she has very small hands. And so she still has some hand issues too, because she's trying to manipulate the dial on the colonoscope is in particular. And, you know, if you think about what's happened in anesthesia all this time, right? They were always going like this. And now they have the screen and they could sit up a little bit, but they've also elevated that table. It's like every one of my anesthesiologists is 6 foot tall. I'm like, guys, what are you doing? The table's up here. Like, I mean, you got to drop it so I can even prep the patient, right? So they're making changes, but they still, all of us have issues as we try to get into the body to do what it is that we need to do. And I don't know
I learned a very good term yesterday called well-being frame shift. Meaning that, you know, we care about the well-being. Obviously, we've been trained to care of the well-being for the patient, but it's time to shift that and make sure that that we all are included in the whole well-being sphere. And all the points you bring up, Marina, are so important. I've learned a lot today, more than I ever could have imagined about ergonomics. I mean, this has been a fantastic session, and I really thank our speakers and our panelists for this tremendous session today. Are there any parting thoughts that you might have before we sign off?
So, great session, Summer. Thank you for organizing this. Couple of commercials. You know, we have the ASMBS meeting next year in Washington, and the great IFSO that you see here in my background in Chile. So hopefully everybody can take a look at the possibility of attending. I know there's another long distance, but it's going to be a great event. Also, IFSO want me to announce that they're launching this MBS Academy. You probably are aware, Summer, that they're going to start doing videos, several of the so surgeons that are going to start putting videos in the website of different techniques. And so it's called Masters of MBS Academy and IFSO. So a new initiative from IFSO. So thank you, Summer.
Thank you. Thank you for IFSO for supporting this. And thank you to our colleagues at ASMBS. Thank you, James. I know you've been working behind the scenes, but it has been a flawless session. All right. Thank you. And this is us signing off. Appreciate it.